Let's address a structural reality that most practice owners know but rarely talk about openly. Your submitted claims are likely carrying hidden errors. Medical coding is a highly demanding administrative function. The codes change annually and payer rules shift without warning. In fact, the 2024 Experian Healthcare State of Claims report found that 46% of denied claims trace back directly to missing or inaccurate data right at the point of submission. Incorrect coding creates systematic audit exposure and a steady, silent loss of revenue from your daily operations. Treating medical coding as a simple back-office task creates a structural vulnerability. Without a dedicated layer of oversight, mid-size practices carry severe, unquantified financial liability. This chart displays Medicare fee-for-service payments for the 2025 fiscal year. CMS reported nearly $29 billion in improper payments, a 6.55% error rate. A significant portion of those errors trace directly back to documentation gaps and coding inaccuracies at the provider level. These administrative failures extend to the practice level. AAPC data from 2024 shows a 19% undercoding rate for office visits, driven almost entirely by knowledge gaps around new coding guidelines. Because of this widespread data failure, federal enforcement is intensifying. The Department of Justice secured over $6.8 billion in False Claims Act settlements and judgments in fiscal year 2025, the highest total ever recorded. The Office of Inspector General uses a tactic called extrapolation. If an auditor finds a $400,000 pattern of inaccurate diagnosis coding in a sample review, that error rate expands mathematically, resulting in estimated damages between $3.5 and $25.5 million for the organization. Extrapolation means a single repeated misunderstanding of a billing rule compounds into a penalty large enough to bankrupt a mid-sized practice overnight. A thorough medical coding audit is a systematic review of CPT selection, diagnosis specificity, and payer-specific modifier usage. Let's look at one of the highest risk failure points, modifiers. These are two-character codes, like -25 or -59, used to indicate that a procedure was altered by a specific circumstance. Misapplying them creates a rapid pattern of systematic overpayment exposure. The clinical documentation itself often sets a trap. According to a 2022 study, over 50% of electronic health record text is copy-pasted from prior notes. That creates a patient record that looks completely full, but lacks the fresh, specific details necessary to survive an audit. Industry organizations like AHIMA and the AAPC consistently recommend regular prospective audits, reviewing claims before they are submitted, and retrospective audits to find patterns. Crucially, these reviews must be performed by someone other than the original coder. Relying on the same overwhelmed staff member to code a clinical chart and then objectively audit their own work is an operational failure. Accurate revenue capture requires a completely independent, closed-loop review layer. A growing number of practices are moving away from the in-house generalist approach. Instead, they are outsourcing their audit functions to dedicated specialists carrying AAPC and AHIMA credentials. These remote teams operate directly inside the practice's existing electronic medical record system. They learn the specific payer mix, understand the clinical nuances of the specialty, and work as a direct extension of the medical staff. Deployment takes 14 days to reach full operation. Because access occurs entirely within strict HIPAA and SOC 2 Type 2 compliance frameworks, patient data remains secure while the audit layer goes live. Built-in controls ensure precision. Supervisors review daily random samples, holding error rates consistently below 1%. This workflow integrates AI smart routing. The system actively sorts standard cases away from complex modifier edge cases, ensuring difficult charts land directly on credentialed human experts. The artificial intelligence acts as a force multiplier. It handles the volume processing and detects unusual coding distributions, freeing the human credentialed staff to focus purely on complex clinical judgment calls. By combining AI pattern detection with dedicated human expertise, practices create an audit infrastructure that clears claims significantly faster than an in-house team, while maintaining the rigorous compliance needed to withstand a federal review. If independent audits are this critical, why don't mid-sized practices simply hire their own team of multi-credentialed coding auditors? General coders earn $50,000 annually, while multi-credentialed coders average $81,000. Adding benefits and turnover risk makes internal hiring prohibitive. An embedded team provides the exact same talent for $399 a week, about $20,000 a year, replacing volatile expenses with predictable fixed costs. Achieving superior compliance and clean revenue capture does not happen by asking your current billing staff to work harder. It is the direct result of deploying a highly efficient, specialized labor model. The federal enforcement environment is aggressive, and the risks are immediate. Practices that have neglected systematic internal audits for the past 12 to 18 months are operating with massive, unquantified liability. You can protect your revenue cycle without committing to a long-term contract. Validate the model inside your own EMR system with a 14-day risk-free pilot from a dedicated credentialed team. The math makes financial sense. The question facing practice owners today is whether you can afford to ignore your own coding data while